5 minutes left. I'll just run through one or two. There are a lot of intraoperative hitches which can happen, and the hitches become more important when you have already done a multifocal in one eye and to handle it. So this is one of the patients. He's a young patient. He has Fuchs, heterochromic iridocyclitis, and this is a complication, and he has posterior subcapsular cataract. So it is unilateral, and since it is Fuchs, I had offered him monofocal, but he works in the Air Force and he cannot afford to wear glasses. So he said, even if I don't get full range of vision, I cannot afford to wear. So I had to implant a multifocal in this patient. So what actually happened is, while polishing the posterior capsule, actually it was a deposit on the posterior side of the posterior capsule, and I ended up creating a rent.
Yeah.
So, and I had planned a restore for him, because that was a lens available. So I would like to have the panel's opinion. See, this patient, I cannot put an monofocal lens for whatever reason, and I have a restore lens with me.
Huh?
Yeah.
Oh, you're asking us. Okay. Yeah.
Will you go ahead with the multifocal?
Can you just repeat that, please? Sorry.
The patient is around a 30-year-old Air Force pilot. He's got Fuchs uveitis, and this was a posterior subcapsular cataract, and I polished the capsule, and there is a rent.
Okay.
So, will you implant a multifocal in that patient? Because the option is there is a monofocal.
There are two things. Obviously, anything can happen, even if, but with a jet of water, if you can polish, that will minimizes the risk. But it can happen even with that. That's not an issue. If it has happened, if it's a small one, if it's a small rent and you can round it off, then you
posterior
can do it.
capsular excess.
That is one.
In this case, anyway, since the AC was filled with a viscoelastic, and there was no vitreous disturbance, I just went ahead. I didn't do a posterior capsular excess. Went ahead and implanted the restore IOL. And one advantage is the axis of platform. We can just gently maneuver it inside. So
earlier, the technicians used to have a multifocal three-piece IOL. So that is also,
But then I placed the, gently nudged the haptic inside, and at the end of surgery, the IOL is very well centered, and the AC is very well formed. I'll go to one more.
Sony, I think this patient, you got away with, results are good. But when you have a PC rent, please understand, you need to convert that into a small PC rent, convert that into posterior capsular excess, because the posterior capsular gives more strength. Yeah. If you try to implant a lens in the presence of a PC rent, that will start expanding.
Stretch. Yeah.
Whatever way you do, it will start expanding. And you'll have the lens either on the table, it will go down, or next day it will be on the macula. Yeah. So
another thing that can happen, even if everything is fine, if it's staying there, when you're doing hydro of the wound, you have to be really careful. If you do too much, then also it can stretch. And
yes.
Here I got away with it, and this is one more last case because there's no time. It's already. This is a cataract in which I tried doing the rexes, and if you see, the rexes ran out. So, what would you do? Would you still implant the IOL in the bag?
Multifocal.
Where is the
multifocal? Yeah. See, it's run out here.
Run out here. Can we pull it back? Because
no, it has gone beyond that area.
See, from the other side, if you can just create.
Yeah.
And if you just have one extension, so you can keep if it's not a multifocal toric, then you can keep the haptic on the sides wherein you have a nice round edges and which are overlapping the IOL. So that can be done.
Yeah, but here what I did is I just cut the rexis margin where it is going out with a Vanus and continued.
Okay. The other way
Yeah,
can
from
be
the same side.
You can go from the other side.
Yeah, I got it from this side itself, and I could complete a decent rhexis from that area. I could complete it.
It may be a good idea to complete the rhexis cut from the opposite margin, which has not run out.
Yeah.
So we can look at the flap motility, and if
Yeah.
there is we can look at the motility after removal of the nucleus.
Yeah,
If the
you
flap
look
is
at
everted,
whether it
then you
is
can
going
definitely place the
posteriorly.
lens in the back.
So I went ahead with a minimal stress, the phacoemulsification with minimum, what do you call, movement of this thing, and removed. In this kind of cases, I feel a plate haptic lens is much more stable than a the other haptics. And here I implant AT-LISA tri-IOL, and it gets very well centered. I try not to tuck it at the area of the rhexis extension, but after a good wash, the lens is very well centered. And in the post-operative visits, it's remained very well centered. In my hands, I think the plate haptic works better when there's a rhexis extension and remains very well centered.
Yeah. So our next course people are throwing very,
Angry
threatening glances in this direction.
I think.
So I think
Thank
in
you.
the interest of time, we should wind up the session.
Okay.
Thank you very much. I'd like to thank all my panelists, all my speakers for making this session very fruitful and very nice discussion from the audience side. Thank you.